Welcome everyone. Thank you so much for coming to our presentation on smoking and vaping in mental health and how to best screen and intervene with clients that we're working with. Before I do the introductions, I'd just like to acknowledge that we're meeting on Aboriginal land, and I'd like to pay my respects to the Gadigal people and their elders past and present, and just acknowledge that as a non-Aboriginal person, it is a real privilege to be able to live and work on unceded Aboriginal land. And yeah, it's really important to reflect on that and acknowledge that. So doing that today. My name's Eliza. I'm a research officer with Mindgardens and the Keeping the Body in Mind primary team lead. I'm just doing the intro today. Our main presenters will be Dr. Andrew Watkins, who is a nurse practitioner by background and has worked in the mental health space and particularly in the physical health space for a really long time. Kind of original member of the founders of the Keeping the Body in Mind program. So yeah, has a lot of knowledge and experience in this area. And we've also got Shruti Raja, who's a registered nurse and the nicotine treatment specialist in the Keeping the Body in Mind primary program. So helps support clients with nicotine cessation. You want to jump to the next one? Beautiful. Just a little bit of context about Mindgardens if you haven't heard of us before. So Mindgardens is a translational research hub. It's made up of 4 founding members, so Neura, Black Dog, UNSW and South Eastern Sydney Local Health District. And the purpose of Mindgardens is really to try and bridge the gap between research and clinical practice, and we're all about improving the lives of people living with specifically mental health, drug and alcohol, and neurological disorders. And yeah, just trying to improve patient healthcare and all of that kind of thing. And so I might go to the next slide now, Andrew, and pass it on to you.
Thanks so much, Eliza. Thanks for the introduction. It's great. And good afternoon, everyone. Thank you for taking the time out of your busy schedules today to come and join this in-service. I think, I'm going to provide some background information around smoking and mental health today. And then my colleague Shruti is going to talk about the wonderful Keeping the Body in Mind primary program, and specifically about the nicotine treatments option that are available with that program. So that's fantastic. So be sure to hang out till the end to get information on what the KPM primary program provides. All right, just to start off, here we've got a picture of the tobacco plant, and I thought this was interesting the first time I saw it because it looks so innocuous. It looks so benign. It looks like something that you might chop up and just throw on your salad, and it would add to the superfood content. But this little plant is responsible for more deaths around the world than any other cause. And when we think about tobacco smoking, as I mentioned, it's the leading cause of preventable death. So just to put this in some sort of context, if someone is a smoker, the reason for a smoker to die is more than likely that it is from smoking cigarettes than of any other cause. So more than 50% will die of a smoking-related illness compared to all other causes combined. Now, it is actually because tobacco contains nicotine, and nicotine is an addictive substance. It is actually in the DSM, and it is the most common psychiatric disorder around the world. But I think the most scary stat on this page is that even though people with a mental illness or other substance use disorder make up a minority of the Australian population, more than half the tobacco sold in Australia is sold to this population. Now, Australia has been a real world leader in getting rates of smoking down. And what we've seen is a fantastic reduction over time. So we've used really good public health messaging. We've been world first around plain packaging and banning advertising in lots of areas. So that's been really good. And I've got two comparison points on the page, and that's between 98 and 2010. And we see the general Australian population smoking rate really decrease over that time. So really about a quarter reduction, nearly 25% reduction. When we compare that to when we've done national psychosis surveys and looked at people who experience psychosis, that rate has hardly changed, saying up around that high 60% mark. So clearly over that period of time, we've seen big reductions in the general population, but this really stagnant kind of rate with people with psychosis. Now, if we move forward towards now, we've made even better strides with the general Australian population. So it's down to about 10% of people over 18 years that smoke now, which is amazing. And again, Australia's world leading on this. Where is it at for people with psychosis? Well, we don't know for sure because in Australia, because we haven't done a comprehensive survey in this area since 2010. But all anecdotal reports and information from overseas leads us to believe that that rate for people with psychosis is still in that 60 to 70% range, which is clearly unacceptable, and it's far higher than any other group in the Australian population. So much higher than our Indigenous Australian population, which is a really significant smoking level in the 30% range, but still far less than this population. So what is it about mental health and psychosis that makes quitting such a challenge for people? Well, we've discussed that perhaps public health messages don't work in the same way. So using plain packaging cigarettes, banning advertising, making cigarettes more expensive, haven't necessarily had the same impact for people with mental illness. I think some of the challenges that arise are sometimes individual ones to the smoker themselves, but also sometimes perceptions that we as clinicians and support workers and the general population might have around smoking. And one of those really pertinent issues is the symptoms of nicotine withdrawal often overlap with many of the symptoms of mental illness, and particularly psychosis. And when people are quitting, I think there's a degree of nervousness that goes on, and people go, oh, those symptoms, they're consistent with when that person got unwell that other time. And so are they getting unwell? Oh, maybe we better stop this this quit smoking business. Maybe it's just safer to smoke. And it gets confusing and people worry. But nicotine withdrawal is a separate process, and so we need to be mindful of that. So that's one of the reasons. We know clearly that some of the interventions that do work for the general population also work in people that experience mental illness and psychosis in particular. What we do know, though, is that a higher level or a greater level of support is needed for people with psychosis, because there's added issues like medications that can be affected by smoking and smoking cessation. So some of those, there's a couple of antipsychotics, for example, that are affected, the levels of those, but also things that I'll talk about a bit later, like caffeine consumption and alcohol. All of these things can be a touch more complicated in people that experience psychosis, but we'll talk through how to manage that. And that's not a reason for people not quitting. As I say, all of these things that we worry about, but the biggest issue is that if people continue to smoke, that is the most likely reason they're going to die prematurely. So I really like this slide, and I think it really articulates one of the things that we have Australia. So on the left-hand side, we have we talk about equality, and Australia is really good at providing a real equality framework for healthcare, like through the Medicare system. So that the idea is to not leave everyone behind, so that we give everyone a leg up to go, okay, we'll help you support your health. And so there's a lot of things that are not out of pocket, although that's obviously become more challenging in recent years. But we're in a much better situation than most countries when it comes to providing some equality in healthcare. An equity model of healthcare, however, recognises that perhaps not everyone needs the same level of benefits and support. And so if we take the guy in the blue shirt there and imagine for a second that he's Gina Reinhardt, and we recognise, well, you know, Gina Reinhardt, she's got access to Medicare, that's there and things, but she probably doesn't need it because she's a billionaire and she probably can pay her own way. But nevertheless, she's got Medicare. And then the little person in the purple top, if we could imagine that was the population of people that experience a severe mental illness, and we recognise that there are some disadvantages that this group experience, and that healthcare services need to provide additional supports. And I think that's very much the case for smoking cessation as well. And as it currently stands, there are not a lot of extra supports available for populations that need it when it comes to smoking cessation. So why is it important to address smoking in this population? Well, let's start off with the equity argument that we're just talking about. So everyone that smokes should receive the right amount of support to quit. And as I mentioned, vulnerable populations really have been left out of this mix. It's the leading cause of morbidity and mortality, not only in the general population, but also in people that experience a severe mental illness. I don't need to tell you how expensive cigarettes have become over the years, with mostly good intentions, but that has, when people are addicted, people will go without food before they go without their cigarettes. So it creates a really significant financial burden on the individual. Then, of course, there's the passive smoking issues that people experience. And finally, the cost to the health system and society in general. We've got loss of life, but also the expense that it is to treat lung diseases and cancers and all the other problems that are associated with people that smoke. So why are cigarettes so addictive? Well, we mentioned before that nicotine is the element within tobacco and smoking that causes the addiction. And people enjoy smoking because, initially at least, because nicotine binding to receptors actually releases dopamine, which is the same sort of feel-good chemical that we get when we exercise or we achieve something, and it makes us feel good, and it gives us feelings of pleasure and calmness with that increased dopamine. However, when people smoke a cigarette, it has a very short half-life. So the dopamine release, the nicotine starts to withdraw from our body, and we get dopamine decrease very quickly. In fact, it starts happening, the half-life is as short as 3/4 of an hour. So really short time frame. And what happens then? So as soon as someone stubs out the cigarette, a withdrawal process starts to begin. And the addiction part is that smokers are then craving the cigarette that's got the nicotine to try and restore some pleasure, but mainly to avoid those symptoms of withdrawal and craving that people receive. So, and that's where the challenge lies. Now, in terms of people who experience severe mental illness and smoke, do they have a desire to quit? Absolutely, they do. But it is a challenge. You ask people that smoke and you have conversations, and most people have got an interest in quitting. This is a study that was done in South Australia where they had over 1,000 people that experienced psychosis reply to this study asking about their tobacco use and their interest in quitting. And the reasons that people gave for wanting to quit smoking is actually really reflective of the general population. So it's the same. So, you know, health reasons are really high up there, financial reasons, health and fitness, but also right up there is, you know, the impact it has on other people. So these things are nearly identical to what the general population says. And so the reasons there are the same. So how do we go about assisting people in the process of fulfilling their desire to quit smoking and be free of that addiction process? Well, there's two parts. There's the psychological and behavioural interventions, and then there's the pharmacotherapies. People get the best results when these are combined. So when they have the pharmacotherapies to ease the nicotine withdrawal process, along with the psychological support. So, and we know that it's not, you know, that the nicotine addiction is part of the process, but there's also a habit there. And that habit also people need help in assisting to break those habits and those associations they do have with smoking. Now, one of the things I'm going to touch on today is the tobacco treatment framework that Mindgardens has developed in consultation with a whole stack of experts in the field. And really, that you'll see a QR code here and a few times on slides. Now, what that QR code does is it will take you to the resources that I'm showing you, but also to a stack of other resources around physical health management for people that experience severe mental illness. So there's a tobacco treatment framework there, also managing cardiometabolic health. There's video guides there, and there's also some consumer guides, and there's also some oral health stuff. There's a stack of really good, juicy information there that clinicians and support workers, primary care can all use to assist them in the process of improving people's physical health. So the tobacco treatment framework, we've got two versions. We've got one that's really focused on the pharmacotherapy that goes into minute step-by-step detail. Okay, here's what you prescribe and when you move on to the next stage. But we've also created an overall guide, which is a bit more of an overview of what we can look at as, even if we're not prescribers, okay, how do we support people to quit? With the two key things to start this off with, the two green lines at the top and bottom of this, and that's to offer support throughout the process with things like cognitive behavioural therapy and motivational interviewing. So we can keep people on track and we can focus on them on the goal that they've made to quit their smoking habit. We also want to really regularly review people for nicotine withdrawal symptoms and adverse reactions. As I say, the biggest problem that people have with stopping smoking is the withdrawal symptoms from nicotine, but there are ways that we can manage that, and there are potential adverse reactions that are associated with stopping smoking, and we'll go through in more detail what they are. Now, the first step of this is the three-pronged step of asking advising and helping people who smoke. So asking is just keeping it on the agenda, asking people regularly about their smoking, because it's not always on the first attempt that you ask someone that they talk about their smoking and say, yeah, no, I want to quit. But it might be when someone's in the right frame of mind, it might be that something's particularly happened in their life, but it's about keeping it on the agenda. And it can take all of about 30 seconds when you catch up. Now, for those people who do smoke, we want to advise the people that do smoke that quitting is a really good option and that continuing to smoke puts their life at risk. That's not, sounding, unnecessary alarms or anything like that. That's the reality. We know that people who smoke are likely to die prematurely from that very reason. And finally, we want to be able to help people who are interested in quitting. So we want to help assess by asking how much they smoke and things like that. And we want to be able to treat their dependence, whether that we might be doing part of that ourselves, but we might also be referring on to another service. For example, the Keeping the Body and Mind primary service that can really work with expertise around this. And some of the things that I mentioned before, psychological and behavioural interventions, really don't underestimate how powerful brief interventions are. We don't have to go into big half-hour spills about smoking cessation and how bad smoking is for you. People pretty much already know that. But it is about, as I say, keeping it on the agenda, asking about it, asking whether people have got any interest in quitting and, or framing it. What would it take for you? What would make it a viable thing for you to quit smoking? Or what would have to change? Using motivational interviewing. So if people are pre-contemplative, being the cheer squad and helping them frame a goal so that they go, yes, this is something I want to do. And then CBT strategies are really important. As anyone that's worked with tests like carbon monoxide meters, and FEV1 tests are those tests where you kind of blow air and see if you can raise the ball. So it tells you how strong your output is. But the carbon monoxide meetings, for example, are amazing. Every time I've used them, people come in and they associate this, like they want to see their score going down. They're really motivated and they ask to come in and I want to see what my score is this week. And it's really important to just not say, this is what you've got to do. You can talk about plans and provide, expert advice, but you want the plans, like all things, we want them to be ideally consumer-led. That doesn't mean that we don't have any role in it. It means that we help shape it, but you want the consumer or the individual to own what they're doing, not something that's being put upon them. So brief interventions, what are we talking about? We're talking about that every person that smokes should be advised to quit, and that taking medication, as in varenicline or nicotine replacement therapy, are the most likely things, as well as advice and support, is better than advice alone. So the cold turkey method of not using a replacement doesn't work as well. Answering people's questions. So, for example, does hypnotherapy, acupuncture, and stress management help quitting? Well, some people will say, oh, I knew someone that did hypnotherapy or they did acupuncture and they quit smoking. That's fantastic. And look, that's great. That's worked for some individuals. But when they've done, the gold standard randomized control trials looking at this, there is no difference between these methods and placebo. So it's not to say that it won't work for anyone. If it has worked for them, fantastic. But if we're coming from an evidence base, we're saying that so far the evidence hasn't showed that those methods are successful in assisting people to quit smoking any more than a placebo treatment is. The other thing is saying, oh, I've been smoking too long, I'm too old, why bother quitting now? to reinforce that there's health benefits to quitting at any stage. Of course, ideally, we want to do it as early as possible, but at any stage you quit, that's of benefit to the individual. Okay. This is something that sometimes people find a little bit controversial, but I think if it's framed the right way, it's not controversial. I think that this can still take part of a, recovery-based, strength-based model, but assessing people's readiness to quit is not currently based on evidence. So if we ask people, do you want to quit? That infers some sort of commitment that someone might not be quite ready for. They might be pre-contemplative. The concept of opting out of treatment is much more ethical. And so what do I mean by allowing people to opt out of treatment? So, for example, if you go to your GP, generally speaking, the GP takes your blood pressure and goes, you know what, this is too high. This is the second visit you've had and your blood pressure's been too high. They tend not to say, are you ready for treatment? They say, look, your blood pressure has been consistently high. I'm going to give you a script for taking an antihypertensive, a medication to lower your blood pressure. Here's the prescription. Now, of course, it is your choice as to whether you fill that prescription or not. No one is ramming that antihypertensive down your throat, but the recommendation is coming through. And so I think that we can frame smoking cessation a little bit more like that. Frame it as if the person is saying, okay, smoking's bad for you. Let's see how we can sort that out for you and what can we do to help you do that. And the person can still say, no, thanks. And that's fine. And that's considered, at least in my book, a much more ethical way of going about treatment. So when we talk about pharmacological interventions, varenicline is actually a safe first-line option for most people on psychotropic medications. Now, there'll probably be people on this call that go, oh, varenicline or Champix, as one of the brand names for it is. Oh, yeah, I've heard things about that people have trouble on it, or it makes people suicidal or things. I'm going to talk through that. The other thing that I wanted to say was NRT can be used safely at the same time as varenicline. Now, there's a reason that varenicline is recommended as a safe first-line treatment, and that is because for a proportion of the population, varenicline, and people may have seen this, varenicline can be a miracle cure for people. Some people start taking varenicline and the response is, you know what, I just don't feel like smoking anymore. And that's amazing. And it's worth trying it just if people fall into that category, because if people fall in that category, it is by far the simplest way to quit smoking, because it just completely stops those cravings that they have. Now, for another portion of the population, it reduces the desire to smoke, but doesn't take it away completely. And that's really the population where you go, okay, well, you're saying it's helping a little bit. So what we'll do is we'll continue with it, but we'll add in some nicotine replacement therapy on top of that to improve its effectiveness. And a lot of that population have good outcomes. There is a third group in this where varenicline doesn't seem to have much impact at all. But that doesn't mean just because you've tried varenicline with, a couple of people and you haven't had any successes that you should, wipe it from thinking about using it. Not the case at all. It's really worth trying that first line. Now, I want to speak a little bit to the risks that people associate with varenicline or Champix, because when it used to have this black box warning on it, do not give this to people who have mental health conditions. It's dangerous and could destabilize their mental state. Now, that has been debunked well and truly, and that warning has been completely rescinded. And look, I just wanted to show you, this is stats. We don't need to go into too much detail, but this was looking at a big study with over 4,000 people on it that were given various forms of nicotine treatment to try and manage their smoking withdrawal. And they looked at neuropsychiatric adverse outcomes. And so you can see we've got varenicline, bupropion, nicotine replacement therapy, and placebo. And remembering that there's over 1,000 in each group. And we can see for these groups, the numbers of people that had adverse neuropsychiatric effects. So that they're all in single digits. Reassuringly, right down the bottom, we can see that no one completed suicide. Only a couple of people right across the study out of 4,000 had suicidal ideation, and a couple had suicidal behaviour. So this is big. And the other thing that's really important with all this is it's the same as whether you took varenicline, bupropion, nicotine replacement, or in fact that you didn't have any medication except for a placebo at all. So there is no added risk of any of these methods over placebo causing neuropsychiatric adverse outcomes. So let me say again, the conclusion of the study was that there were no increases in neuropsychiatric adverse events attributed to any of the medications, but we're focusing on varenicline here. And this study also looked at efficacy and said clearly varenicline was more efficacious than placebo, nicotine patch, and bupropion in helping smokers achieve abstinence. And that's why we recommend it as the first line treatment. The combination therapy, the idea of using varenicline with patches or other oral NRT replacement products, that is a safe process, and it's recommended that you start with varenicline, and if cravings persist, add in nicotine replacement therapy. Okay, so some people might not want to use varenicline or Champix for various reasons. It might not be suitable, might not be the first choice. Now, what we want to do then is use nicotine replacement therapy. And really importantly is people can start on that before they commit to quitting. So they can put on a patch, for example, and say, oh no, I'm not ready to quit. That's okay. Keep smoking, wear a patch. That's fine. It's not going to cause a problem. And, you know, if you do that and they come back the next week having worn a patch each day, and you say, well, how many cigarettes have you smoked this week? And a lot of the time, what happens is that, oh, actually, yeah, since been wearing the patch, like, I only smoked half the number of cigarettes or something, and I didn't even mean to. So people say, oh, well, nicotine's the addictive substance, right? That's the bit that causes the problem with, you know, wanting to keep doing it. So why are we using it as a treatment? Let's look into nicotine itself. Nicotine is itself, it's colourless, it's odourless, and not in itself carcinogenic, so it doesn't cause cancer. It is, however, highly addictive. And as I mentioned before, it's very short acting, so its half-life is between about 40 and 120 minutes. So essentially that means half of the nicotine is metabolized by the body in between 3/4 of an hour and 2 hours. So you've got half as much in your body as when you took it in. Couple of warnings about nicotine and looking at you know, different methods of smoking cessation. So some people go, there are some products on the market that say, oh, we've got cigarettes with lower nicotine. What happens is people naturally regulate the amount of nicotine that they're used to. So if they smoke a low cigarette nicotine, they're actually doing themselves a disservice because they are probably going to smoke more cigarettes than they usually do to get the same amount of nicotine, or they're going to draw harder on each cigarette. Now, both of those things, smoking more cigarettes or drawing harder on the cigarettes, is actually doing more damage because the majority of the damage is coming from the other elements of the tobacco and all the chemicals that are added. And so it leads to, as I say, compensatory smoking. Exactly the same thing happens if people say, well, I'm going to cut down on the number of cigarettes a day. So I smoke 20 a day at the moment. My aim is to reduce that to 15. And they might succeed in that, reducing 15. And that would be very good from saving money point of view. However, same thing, people are going to draw harder and longer on those cigarettes to get the same amount of nicotine that their body is used to. It's not even a conscious process. Smokers will naturally titrate their blood levels of nicotine very accurately. The last thing about nicotine that's really important, sometimes people worry, oh, if I give nicotine replacement therapy and people keep smoking, or if they have too much of the gum or something like that, I'm going to make them sick, or it's going to be bad. I'm going to cause nicotine toxicity. Nicotine toxicity is extremely rare, especially in smokers. Now, really nicotine toxicity you see with two groups, and it's groups that tend to find nicotine replacement therapy they're not supposed to, and they are kids and dogs who are completely, nicotine naive, and they suddenly get this dose of nicotine, and it's like things. But mostly the toxicity things, if someone did have too much nicotine, they're probably like you feel a bit nauseous. If they had much more than they used to, they might start vomiting or get diarrhea. In extreme cases, and this is like more dogs and the children thing, finding NRT that they shouldn't use, tachycardia and convulsions. But that's not going to happen to a smoker because they are used to a high level of nicotine. When we give people nicotine replacement therapy, most of the time we are massively underdosing them and delaying, so they're not getting their nicotine needs met. If we look at this graph, that brown line up the top, which is the cigarette, you can see that in the matter of a couple of minutes, you get a really peak increase in your nicotine concentration in your blood. So you have a cigarette, you get immediate relief on your nicotine cravings. Really successful for that. Now, if we look at the bottom level, that is the patch. What we see is we know that we usually wear patches for 16 or 24 hours, but they've got a very slow build up, and overall, they don't deliver a high level of nicotine concentration. What patches are absolutely brilliant for, though, is it stops people ever falling to having a zero level of nicotine concentration. So it stops the extremities of craving, which is really important. And that's why when we talk about NRT, that we talk about combination nicotine replacement therapy. So the patch, and then not just using the patch, but using one of the oral or short-acting forms on top of it. So we've got a couple of examples here. We've got inhaler and gum, but you've got other things like lozenges and sprays. They're all short-acting versions of nicotine replacement therapy. Now you can see while they still don't match a cigarette in terms of speed and quickness, speed and amount of nicotine that they provide, we can see that they are much closer than the patch. And the idea is to have the patch to have that baseline level and then to boost it up with any short-acting form. Really, when you start off, say, as often as you need it. We shouldn't be putting limitations on this because people, as we know, I spoke about before, will actually naturally titrate their levels. So the long-acting patch, along with one of the short-acting forms, can be safely given in combination and should be given in combination. We've said that there's a very low risk of nicotine toxicity from NRT for smokers. There's also a very low risk of addiction from nicotine replacement therapy. And the reason for that is because they're slow release versions. Addictive substances tend to release very quickly and fade very quickly. And that's what we see with cigarettes and the graph that we had before. We get this spike and rapid decline. So within 3/4 an hour, 2 hours, half of that is already gone. And nicotine obtained from NRT is much safer than that obtained from smoking tobacco. Finally, the last step is, it's not when people stop smoking that you go, right, that person's done. It's really important providing ongoing quitting support. The risk of relapse is high, and we want to continue whatever treatment that person is on after the person stops smoking. So looking at, even though the person might stop smoking, it's really recommended that you actually do the second course of varenicline anyway, because it greatly reduces the risk of relapse, and very slowly fading out any nicotine replacement therapy, even though the person's not smoking anymore. People have much better outcomes when that happens. Now, I mentioned, as I say, I'm not going to go through these details, but just to let you know, the QR code is there. We will send out a copy of these slides to all the participants as well, so you can look on this. But this resource takes you through step by step as to, okay, what do we do in different situations around prescribing and where to step. Looks like there's a lot going on when you first look at this slide. But really, if you take it step by step, it is actually quite simple, because it flows very naturally. On the rear of this framework, we've got more information about the Ask, Advise, Help and what we're doing and where extra support can be realised, behavioural support. But then we have lots of information around the medication interactions, both with psychotropic medications, including things like clozapine and olanzapine, which are the two important drugs. Now, essentially, what we talk about with clozapine and olanzapine is that it's possible that people might be able to get dose reductions. And I'll talk a little bit more about why that is on the next slide. But also, on the back, it's talking about other interactions, including caffeine and alcohol, which I'll also talk about in a couple of slides' time. And we've got information here about, okay, what do the withdrawal symptoms look like? What are potential adverse reactions that people have? And some of the common troubleshooting things that people have with NRT and varenicline, and how we might be able to overcome them. And there's lots of you'll see lots of blue writing on things. All those things are links where further information can be obtained. Now, when we have a cigarette, it's actually the smoke that's causing one of the biggest issues, or the PAHs. Now, smokers often are on higher levels of medications because of the PHAs or tar, not actually the nicotine. And so quitting may affect the levels of some of those medications. Mentioned clozapine and olanzapine are two of the common ones in the mental health space. There's a more comprehensive list on the back, and also links of the resource I was just showing you. So it doesn't mean that what New South Wales Health says is dose reductions in those medications can be 30 to 50%. However, I never recommend people go and just cut medications. What we want to do is closely monitor the actions or side effects of those things. So this is the smoke, or the tar, is all to do with liver metabolization and how available these drugs are in the bloodstream. And so when we quit smoking, these drugs become more available. And so in many cases, dose reductions are possible for people. And of course, that is another selling point for people who might be considering quitting. Cross-tolerance. I want to touch on two things quickly before I finish up. That smokers drink twice as much alcohol as non-smokers. And that is to do with two things. One, alcohol increases the amount people smoke, but also smoking doesn't cause, when you smoke, you don't absorb as much of the alcohol. And it's interesting, one of the things that the police will not let you do if you get pulled over for drink driving, your initial test is over the 0.05 limit. The one thing they will definitely not let you do before they get their secondary test is to have a cigarette. And that's because a cigarette lowers your blood alcohol level, and it can actually reverse your, cognition and coordination effects. So I didn't tell you that, and don't use that, but that's just to draw out the example of how significant the impact is of cigarettes on smoking. So people that are quitting, they're going to be much more sensitive to alcohol, and they're probably going to they need to be aware that they might become inebriated much quicker than they did when they were smoking. An even bigger issue amongst many of the populations we work with is caffeine consumption. And those of you that work with people with psychosis will know that some people with severe mental illness will consume vast quantities of caffeine, so lots of Coca-Cola or coffees or energy drinks. And really, it's important that education is provided around this. So if people are quitting and they're reducing the amount of cigarettes they're having, then their caffeine tolerance can actually halve. So what that essentially says is that people will be buzzing, and that in itself can cause problems in terms of the way people feel if they've suddenly got twice the amount of caffeine in their system than they're used to, even though they're having the same amount. So it's recommended to ask people that are quitting cigarettes to reduce their caffeine by half for the first 2 weeks. Otherwise, it's really going to interfere with sleep. And a lot of the time, nicotine replacement therapy or other treatments get blamed on, I just can't sleep since I've been on this nicotine replacement therapy or this varenicline. It's far more likely that they haven't cut down their caffeine consumption and they're actually buzzing with twice as much caffeine in their system. And lastly, before I hand over to Shruti, just want to touch on vaping, because that, it's a big issue. And is vaping actually a solution to quitting smoking? Again, you probably know people that have switched from smoking to vaping. And is it less harmful? Probably. Is the jury still out? Yes, it is. So the College of GPs says that there is not enough evidence at the moment to say that nicotine-containing vapes should be prescribed as a first-line treatment. Perhaps it's an option where you've tried everything else that doesn't work. Maybe this is harm minimisation, but we still don't know what the long-term effects of vaping is. Conversely, and this is particularly an issue for young people, but people who have never smoked but who vape are 3 times as likely to take up tobacco smoking as those who don't vape. And just to give you an idea of the trends that are happening, so on the graph, on the left-hand side of the graph there, you've got smoking rates over time since the turn of the century, since 2001, 1824, and that smoking rate has just fallen through the floor. It's gone down really well as well with older people, so 50 to 59 in this age group, for example. But we've got exactly the reverse happening with vaping, where vaping is e-cigarettes becoming very popular with young people, and we're very worried about that trend and the conversion to potentially smoking cigarettes with those things, but also the long harm of vaping. Now, thank you for listening to this. Please hang out now, because I'm going to pass on to Shruti, that's going to tell you about the Keeping the Body Mind Primary program, and specifically about what Keeping Primary offers around support with smoking. Over to you, Shruti.
Cool, thanks, Andy. I'll keep it nice and brief because, I think Andrew's covered a lot of the theory and background that KBIM kind of uses. So I'll get into it. I'll just say next slide if I want to go. So next, please. Just a bit of background into what KBM Primary is. I think you've got to click next a couple of times to bring the stuff up. So clinicians that are on board, we've got an exercise physiologist, a dietitian, a peer worker, and myself. Primarily a service that targets physical health intervention. We're completely free to the consumers. So the population obviously we work with is those people with severe mental health illness. It's very flexible. We operate out of the lifestyle clinic in Randwick. It's quite nice. It looks like a little home, but there's a gym and lots of equipment inside. Just as a caveat here, the EP and the dietitian at the moment have a bit of a wait list going. So we will always communicate that with the client and the referrer. But I guess for the purposes of today, I'll only sort of speak about the nicotine treatment stuff, which there is no wait list for at the moment. Next slide, please. So around eligibility criteria to access the service, between 18 to 75 years of age, they can't be accessing current public mental health services, and that just means that they are not, in a CES-led mental health program, and they don't have access to like lifestyle intervention support already. The program KBIM Primary is mainly designed to catch those people that fall through the cracks that might not necessarily be receiving that formal support from outpatient systems. So that's what that means. Diagnosis of a severe mental health illness. So currently, bipolar disorder, schizoaffective disorder, schizophrenia, or major depressive disorder with symptoms of psychosis, or if they're on antipsychotics. So that's our current criteria, and residing within the Saspen region, which is quite large. I think it's like all the way from Cronulla up north. And referrals can come through from anyone, GP, psychiatrist, anyone who feels that their client could benefit from this intervention. Next, please. So just to provide a bit of an overview of what the service really is, all of the clinicians, we try to operate, really individualized trauma-informed and mental health-informed sessions. We've got good frameworks in place and a bit of experience working with this population, and we always try to make it very flexible and easy to access. The exercise sessions in the lifestyle clinic, like I mentioned, there's a little gym and facilities there. Next. And that's a bit about our dietitian and how, so she also operates out of our lifestyle clinic, and she does all her sessions through there as well. Sam and I, so Sam is our peer worker, and she provides that lived support experience and helps the clients sort of navigate our service and links people in with all the different clinicians. They can see one of us, they can see all of us. So it's quite flexible. And the quitting and vaping smoking, that's sort of where I come in from. I won't go through this too much because it's really just reiterating what Andrew's already mentioned, and it's just a bit about the challenges that this population faces and what the KBIM program is trying to intervene with. So all these statistics of sort of how much more susceptible to health risks that people with severe mental illness are, and how much more likely they are to smoke and vape. Next. Like Andrew mentioned, it's not that we're not seeing people wanting to quit, and unfortunately that translation of the general reduction in smoking rates that we see in the population, that's not being translated to people with severe mental health illness. That's the intersection that hopefully the nicotine cessation program's trying to address, and helping people along that journey and giving them that weekly or fortnightly structured support. That's where we're sort of trying to sit. Next, just sort of what the service entails. It's over 12 sessions, which is, negotiable, usually an intake and then 10, and then we do a discharge. Weekly sessions are also flexible if the client feels that it's more, they want to do fortnightly, if they want to do telehealth. We'll try to cater to everyone's individual needs. Next. And I guess the main things that we sort of go through are education, and provision of NRT can be given at the beginning. We do have a supply to give to those people who have poorer financial means, but most likely it will be to support them through that initial quitting phase, and then helping them understand how to access that themselves through other professionals. And really importantly, trying to provide coordinated care. So, you know, making sure we're linking people in with other support systems, their referrers are being kept in the loop, that their GPs are really aware if there's any medication changes that need to be made. Yeah, so that's all quite important. This is just a really quick sort of brief overview of what a session might look like, and all the different things that we could talk about. Importantly here is just the feedback and updates to the referrer, because I think the concern is that a lot of people do, especially if they're taking Champix or if they're on antipsychotics, just how to manage that when you're not seeing a client regularly. So weekly sessions is an opportunity for you know, them to get an assessment through us, and then us to update you as the, you know, through their journey. Next. And yeah, this is just if anyone wants some extra information, how to get in contact with us, feel free to reach out, please. I'm always happy to have a chat through any specific cases or clients as well. But yeah, that's pretty much my side of chat, and we're just on time, which is good. Eliza, do you want to maybe just go through this page and what this is?
Yeah, sure thing. Just a couple of things. Andrew already touched on the resources, so the QR code is there for that as well. And then we also have some other educational webinars and some like half-day workshops as well for various things. And the QR code is there as well if you're interested in those.
Yeah, thanks, Eliza. One of the things that might be of particular interest to people, we've got an upcoming workshop on co-designing interventions with, well, it's not specific to mental health consumers, but that's the basis of it, but the co-design, and we've got experts that come in and run that workshop with us so that people can co-design interventions effectively rather than just providing lip service and saying they are, which is, done that course personally. I think it's fantastic.
Amazing. I've just popped the referral link for KBIM Primary into the chat as well if anyone is interested. But we will send out the slides as well, and we'll pop some info about KBIM Primary in that email as well with the referral link too.